clinical implementation of an endoscopic visualization of the cervical spinal cord in cordotomy due for untreatable pain syndromes. So we treated 20 patients with nociceptive type cancer out of malignant cancer who had no success in other treatment options like even putting an opioid infusion pump. The aim of the cordotomy is to interrupt the pain contralateral fibers of the spinothalamic tract. The spinothalamic tract, which resides in the anterolateral column of the white matter of the spinal cord. Currently, this procedure is developed under X-ray guidance. This means fluoroscopy or CT, but we would like to introduce this technique using the endoscope. So basically, the procedure is a patient who is in a supine position, and we will perform the procedure in the lateral aspect of the spinal cervical cord, and the landmark will be 1 centimeter below the tip of the mastoid. The endoscopic view will allow us to have direct visualization and use direct landmark. These landmarks will allow to make a procedure faster, easier, avoiding the shorter the time for fluoroscopy and avoiding the use of contrast medium. So at first we go into the interspace C1, C2. We introduce the endoscope, which is an endoscope of 9.9 millimeters, and then we start to have the visualization of the structures, the arytenoid membranes and the ventral rootlets. We can see also the PR surface of the spinal cord and the ventral, the radical blood, the blood vessels of the spinal cord and the root entry zone for ventral and also dorsal root entry zone. So with this landmark, we are avoiding the chief of making mistakes for the spinal cord. So here is ventral, here is dorsal. This is a left approach, and here we have the dentator ligament and the ventral root. The intermediate point between these two will be our target. At first we introduce the electrode, and once we introduce the electrode, at the beginning we make electrical stimulation. This electrical stimulation should produce sensory alterations, but not motor alterations. If you are producing motor alterations, it means you are too posterior, and it means you are in the corticospinal tract. It means contractions of the neck or the upper limb. And then we do a radiofrequency lesion. This radiofrequency lesion is performed 60 seconds, approaching 75 degrees. It's a thermocoagulation lesion. So we have performed for this study 20 patients with malignant type cancer who did not respond to other options like opioid, even in opioid infusion pumps. This study was performed in Hospital das Clínicas in Sao Paulo, where there is a long experience, more than 1,000 cordotomies performed with the other fluoroscopy technique. So we already know, and either for the literature, that the patients that got better are the unilateral patients. The patient who had unilateral pain, thoracic pain, or limb pain due to malignant cancer. So we tried to perform in the unilateral patients. Sometimes we perform bilateral patients. We did it for a medial line pain. So in total we performed 22 cordotomies. The result, the scale that we use pain, but it's comfortable and fair when there is no change. For our complications, we have a mild motor deficit in lower limb, but with physiotherapy it recovers over a period of 14 days. In the literature is also some loss of urinary control and respiratory problems reported, but with these special landmarks that the endoscopy gives you, you are safer not to have these complications. This is the follow-up. Just we can see how, and we are able also to perform spinal cord tractography to see where is the lesion. Surgical treatment for intractable cancer pain, that the direct visualization of anatomical landmarks makes target determination fast, safe, and the use of fluoroscopy short. You will only use it to identify your space C1, C2, and you don't need contrast medium administration, which sometimes can cause some problems intrathecal. We would like to encourage spine surgeons to use this approach, and it's open now also to do this kind of procedure, intradural percutaneous procedures, even to do biopsies or to introduce this kind of a small endoscope of 0.8, 0.9 millimeters in the sacral roots, or do biopsies of tumors. Thank you so much.
Light image, you can scroll up and down for any image. With CAT scan, there's a Hounsfield unit, which is a standard MRI CT imaging unit. But on MRI, even in the same patient at other levels, the numbers and stuff don't match. And there's no way to quantify as far as I know.
I think what Glenn is asking is, how do you choose the threshold from which you go from your gray level image to your binary image? Is that correct, Glenn?
Well, there are two of them, because we ended up with two problems. One was the gray level for the scoring once we had the image. And then the other one was we had the image itself, and we had to scroll up and down to figure out what image we wanted to put in to have that gray level applied. And what I ended up with was we played with this forever. And finally said, I play with this one, I'll get this number, I'll play with this one, get this number, and end up at 25%, which is what I think it ought to be. Okay, so it was just me looking at it. In fact, we've gone back and done a similar study that's looking at a different endpoint. But we just looked at it, eyeballed it, and said, okay, this is less than 25%, less than 50%, less than 75%, more than 75%, because we couldn't figure out a way to quantify it. So if you figure it out, please let me know, because I mean, we struggled with it. I've talked to engineers and radiologists and everybody else I can think of to try to figure out a way to actually quantify it. We said, hey, if it's CT, we can do it, and MRI, it can't be done.
Do you have a response to that?
It's a great point, I think.
Maybe I can ask Ari to comment, because Ari is actually a physicist who does a lot of MRI work.
Yeah, I was just going to, I guess, look it up on the issue of segmentation, so trying to distinguish the fat infiltration from the rest of the surrounding muscle. You might need a different contrast. So in MR, you can generate fat-only images or water-only images using a technique called two-point TEIXEIRA or three-point TEIXEIRA method. Maybe having two sets of images might help in the segmentation process. I haven't done segmentation on exactly that part of the anatomy, but in trying to delineate cartilage, for example, in the disc from surrounding tissue, it is challenging. It is challenging. And one way perhaps is to have a software program where you can actually place, where the user can actually place a seed in the region of interest, like the disc, and have some kind of region drawing algorithm that finds the boundary of the disc.
Well, one of our residents who has a background in physics has come up with an idea that we're trying, but we're now trying to figure out which way to do it, which is to put a reference sample on the patient when they have the study done.
Yeah.
So you can use that as your reference to say this is 50.
Right.
And if you standardize it to that, then you can go and say all of them now will be measured the same way. But that involves a prospective study. It involves something. What we're trying to do is trying to find something to be easily applicable to every MRI, whatever.
Absolutely.
But this is the one that requires that you have to do it ahead of time, mark the patient, and get the MRI to find out.
Okay, we're sort of running out of time, so I think there was one more question from Emiliano, or there's another one there. Yes, go ahead. Go ahead.
Yeah. Dr. Contreras, why do you use C1 to level for endoscopy endoscopic, no other level?
To which author are you addressing your questions?
It's for me.
Oh, okay. Sorry.
because it's the best spot to interrupt the spinal contralateral pain information. And we found that here the space is bigger than lower between the dura mater and the spinal cord. So with an enough quantity of CSF, you can really have a beautiful image. Down, the dura is closer to the spinal cord, so you don't have that much space.
Okay. No, that answered your question. Okay. If there are no other questions, I'm sorry, but we've sort of run out of time and we have to make room for the next session. So thank you again for all of the speakers and for your audience.